This presentation on obstetric management of breech and assisted vaginal breech delivery meant for self-learning is targeted to undergraduate and postgraduate students in obstetrics and gynecology. This can also be used by general, BSc and MSc nursing students in OBGYN. The plan of presentation is first 15 minutes it will be a theory based PowerPoint presentation followed by 15 minutes of video demonstrating assisted vaginal breech delivery on mannequin. Breech is a malpresentation, the incidence of which varies from 30% at 30 weeks to 3% at term. It acquires importance because of the fact that the chance of anomalies, complications during delivery, and birth injuries are 3 times higher than the normal presentation. It needs an expert antenatal and intranatal care, preferably at a tertiary care center. There is a higher incidence of cesarean delivery, especially in primigravida term breech. However, one must know the management of breech as well as know the skills of assisted vaginal breech delivery. Accordingly, the objectives of this presentation are to learn the types of breech, to make a diagnosis of breech presentation, to make decision regarding mode of delivery, to understand normal mechanism of labor in breech, to know the types of vaginal breech delivery, to understand principles, preliminaries and steps of assisted vaginal breech delivery, and finally to tackle the difficult situations during assisted vaginal breech delivery. Let us first take up the types of breech presentation. There are several ways of looking at the types of breech. One is the type based on the attitude of the baby. It is called complete breech when there is flexion at all joints or universal flexion. Incomplete breech is one where there may be flexion at some joints and extension at other. It's called footling presentation when there is extension at the hip and knee joints. Kneeling presentation is one where there is extension at hip but flexion at knee. Extended or frank breech is one where there is extension at knee joint and flexion at other joints. Frank breech is the most suitable one for assisted vaginal delivery. Types of breech in pictures. Complete breech or flex breech where there is flexion at all joints. Incomplete breech, frank breech where there is flexion at hip joint, extension at knee joint. Kneeling presentation where there is extension at hip joint, flexion at knee joints. Footling, there is extension at hip as well as knee joints. Another way of looking at types of breech is based on its clinical presentation. Uncomplicated breech is one where there are no other associated obstetric or medical complication. Whereas complicated breech is one where in addition to being breech, there may be any obstetric, for example prematurity, twins, contracted pelvis, placenta previa, or medical complications such as preeclampsia or GDM may be present and they adversely influence the prognosis. Uncomplicated breech is the one which is most suitable for assisted vaginal delivery, whereas complicated breech should go for elective caesarean delivery. This slide shows the signs that can diagnose two major types of breech. On fundal grip, the hard head is ballotable in a complete breech, whereas it is non-ballotable in frank breech as it is splintered by the two extended legs. On lateral grip, in a complete breech, the back is on one side and the irregular limb buds are on the other side, whereas in frank breech, because the legs are extended, there won't be limb buds felt on either of the sides. Pelvic grip will show a soft, broad irregular mass in a complete breech, usually not engaged because it is irregular, whereas in frank breech, it's a soft, small conical mass usually engaged. On auscultation, the hard sounds are heard at a higher level in a complete breech because it is usually unengaged, whereas they are heard at a lower level because of a easy engaged frank breech. On pervaginal examination, one can feel soft parts through the fornix during the antenatal period in complete breech, whereas hard sacrum is felt in a frank breech. In labor, on vaginal examination, one can feel the tuberosities, sacrum, and two heels of the feet. So totally there will be 5 points, whereas in frank breech one can only feel the two ischial tuberosities and maybe the coccyx. It is important to differentiate the face presentation from breech presentation on pervaginal examination. The confusion is because both face and breech have two bony eminences and one opening. But in face, the two bony eminences that are malar eminences and oral opening at a triangular relationship. Whereas in breech, the two ischial tuberosities and anal opening are in a straight line relationship. Deciding the mode of delivery is extremely important to avoid complications during vaginal delivery. Here, I would like to elaborate the factors favoring elective caesarean section. Age is an important factor in any situation. Similarly, an elderly lady is more for caesarean delivery, especially if she is primigravid and presenting at term. Clinical variety of complicated breech and the type of breech, especially foot link, knee presentation, and even flex breech, are for caesarean delivery because the incidence of cord prolapse is higher in these types of breech. Size matters. Bigger the baby, that is more than 3.5 kg, and too small a baby, that is less than 1.5 kg, are preferably delivered by caesarean section. The other factors such as hyperextended head or what is called star gazing sign, and of course an inexperienced obstetrician, it is better the breech is delivered by caesarean section. These points are more or less reflected in Zattuccini-Andrews scoring system. Mechanism of labor in breech. Though complex, it is important to understand it in order to understand the steps of assisted vaginal breech delivery. It is different from the mechanism in vertex presentation in that the principal movements occur at three places: buttocks, shoulders, and head. Let's take up mechanism of labor at the level of buttocks first. When the bitrochanteric diameter crosses the pelvic brim, we call it engagement of the buttocks. Thereafter, there will be descent, and descent continues throughout. As we know, whichever part has to deliver should align in anteroposterior diameter of the outlet. Consequently, there would be internal rotation of buttocks by 45 degrees. After that, with the lateral flexion of the trunk, the delivery of the anterior hip occurs, followed by delivery of the posterior hip. Once the buttocks are delivered, there will be twisting back of the buttocks called restitution. The gray line represents bitrochanteric diameter, white line represents bisacromial diameter. There will be just internal rotation of the bitrochanteric diameter by 45 degrees, delivery of the buttocks. After that, there will be twisting back of bitrochanteric diameter called restitution. The next is mechanism of labor in shoulders. It's a bisacromial diameter that engages in the same oblique diameter of the pelvis as the bitrochanteric diameter got engaged. Descent continues, and the internal rotation of the bisacromial diameter at the outlet in order to deliver. The trunk also rotates externally by 45 degrees. The delivery of the posterior shoulder occurs, followed by anterior. Then the body goes back, restitution. There will be external rotation of the body, which corresponds to internal rotation of the head. Now there is internal rotation of the shoulders. When this happens, the bitrochanteric diameter also rotates inwards because it is dependent on the shoulder. After the delivery, there will be restitution of the shoulders. Now head comes into picture. The sagittal diameter of the head occupies the opposite oblique diameter in the pelvis. With the internal rotation of the head, there will be external rotation of the shoulders. The last one is mechanism of labor in head. The engagement occurs with suboccipitofrontal diameter. With increased flexion, it may change to occipitofrontal or even suboccipitopragmatic towards the end. The descent continues with increased flexion of the head, and there will be internal rotation in order to align itself in the anteroposterior diameter of the outlet. The delivery occurs by increased flexion. The delivery of the head by increased flexion is depicted in these two pictures. Now let's see the types of vaginal breech deliveries. There are three types of vaginal breech deliveries. The first and the most commonly used is assisted breech delivery. Here, we simply assist the natural mechanism of delivery. Breech extraction is used only in case of emergencies, in that second of the twins with cord prolapse. Here, obstetrician pulls the baby right from the feet. Obviously, it's harmful and causes more injuries both to the baby as well as to the mother. The spontaneous vaginal delivery is not at all a preferred delivery. Mostly, it's a retrospective diagnosis wherein an extremely preterm baby delivers outside the hospital without any medical aid. 10% of the vaginal deliveries in Breech are of this variety. We have now come to the main part of the presentation, that is assisted vaginal breech delivery. First, let's understand the principles. Two main principles of assisted breech delivery are: number one, never pull. One should not pull at any time. If at all, one may give suprapubic pressure towards the end of delivery in order to facilitate the flexion of the head and delivery of the aftercoming head. The second principle is keep the baby's back anterior so that it faces the obstetrician. This principle is also used in caesarean delivery, whereas in caesarean one may have to pull the baby because patient is under anesthesia and cannot bear down. That means in vaginal delivery we have to encourage the lady to bear down. Before I go to the actual steps of assisted breech delivery, let me explain some of the preliminaries to be done. Bring the patient to the edge of the table when fetal anterior buttock or anus is seen. This is important because as the buttocks and trunk emerge, they can hang out from the introitus of the mother, and at the time of delivery of the head, it's easier to do that maneuvers. You may position the patient in lithotomy, though it is not mandatory, so that it's easier to do all the other maneuvers. Catheterization goes without saying before any delivery, so also the breech delivery. It can be an in and out catheter. There is no need of indwelling catheter. Give liberal episiotomy when you see the breech climbing the perineum. In vertex presentation, we call it crowning of the vertex, but here we call climbing of the breech. Encourage the patient to bear down, as I said earlier. Coming to the steps of assisted breech delivery. The most important thing to observe is to allow the baby to deliver on its own most of the time. The assistance is given only at select situations. In fact, I would be using this phrase, allow the baby to deliver on its own, at least 3 times. First time I am using the phrase, allow the baby to deliver on its own till umbilicus. Once you see the umbilicus, gently pull a loop of umbilical cord and keep it aside so that it won't be snapped during further delivery or descent of the trunk. After this, it is important to wrap the baby with a sterile towel to keep the warm and avoid cold stimulus. The next step is the most important and crucial step, that is, rotate the trunk of the baby by using femoropelvic grip to bring the back anteriorly. As we said, it is most crucial step and one of the two principles of assisted breech delivery. Again, allow the baby to deliver on its own till you see the axilla. At this point, look at the scapulae, whether they are winging or they are parallel. If they are parallel, that means the hands are flexed. Gently hook out the arms one by one. If the scapula are winged, then it suggests nuchal position of the arms, and there is a special maneuver called Lausser's maneuver. I am going to talk about it later. After the delivery of arms, again allow the baby to deliver on its own till you see the nape of the neck. This is the third time I am using this phrase. Once you see the nape of the neck, it's time to deliver the head. The aftercoming head may be delivered by one of the three methods: Burns-Marshall technique, Mauritius-Mealy-Viet technique, or a forceps delivery using Piper's forceps. Let's take up one by one. Burns-Marshall technique. It's the simplest and the commonest technique that is used to deliver the aftercoming head. Here, you ask the assistant to give suprapubic pressure in order to maintain the flexion of the head. Remember, in natural mechanism of delivery of the head delivers by increased flexion. The delivering obstetrician will grasp the baby's ankles and maintaining a steady traction and forming a wide arc of a circle, the baby is swung on the mother's abdomen, that is upwards and forwards. The baby's head will automatically deliver. This is the commonest maneuver that is used to deliver the aftercoming head of the baby. If this doesn't help, one may turn to Mauritius-Mealy-Viet technique. In this technique, the baby is placed on the supinated left forearm of the obstetrician. The limbs will be hanging on either side of the hand. The middle and index fingers of the left hand are placed on the malar bones of the baby in order to maintain flexion of the head. The ring finger and little finger of the pronated right hand is placed on the right shoulder and the index finger is placed on the left shoulder. The middle finger is kept on the subocciput region of the baby to facilitate more flexion of the head. And then a downward and backward traction is performed till the nape of the neck is seen. Finally, the baby is carried upwards and forwards to deliver the head. If Mauritius-Mealy-Viet technique also fails, then we have to resort to forceps delivery of the head. The ideal forceps is Piper's forceps, which has got long shaft and minimal pelvic curve. However, if it is not available, one may also use low cavity forceps. Before using the forceps, the baby is wrapped in a towel so that the hands and the limbs won't come in the way. The forceps is applied from below. The left blade is directly applied on the left side of the head as against in vertex presentation, where it is first applied posteriorly and then slowly taken to the left side. Right blade, of course, is directly applied onto the right side. While applying traction, a steady traction is applied and the arc of a circle is maintained as in case of Burns-Marshall technique, and the baby's head is delivered. Now, tackling some of the difficult situations during assisted breech delivery. In a frank breech, sometimes the breech may be impacted. In such situations, a technique called groin or breech traction is applied. The two index fingers are placed at the flexed hip joint and a gentle traction is applied if there is a delay in descent of the breech. Of course, there should not be any outlet contraction. Second difficulty is delivering the extended legs, again in a frank breech. The maneuver used here is Pinard's maneuver. Two fingers are slided over the extended leg until you reach the popliteal fossa, and then popliteal fossa is gently pressed so as to flex the limb. Once the ankles are in reach, the ankles are grasped and the leg is gently pulled out. The same procedure is repeated on the other leg. The third difficulty is delivering the nuchal arms. Lausset maneuver is the one which delivers these arms. The trick here is rotating the shoulders in such a way the lower posterior shoulder, as it becomes anterior, gets automatically delivered. And once that is delivered, the reverse rotation will easily deliver the anterior arm. As shown in this picture, the lower posterior shoulder, as rotated, gets delivered or under the symphysis pubis, and after that reverse rotation will deliver the anterior arm. Having understood the theory behind the management of breech, especially assisted vaginal breech delivery, let's now watch for another 15 minutes the video demonstration of assisted vaginal breech delivery on the mannequin. Today I am going to demonstrate the steps of assisted breech delivery. Before I go on with the video, I want to put a disclaimer. This is exclusively to show the steps only. The mannequin as well as the dummy is slightly harder, so the steps may appear a little rough. We have to follow principles of assisted breech delivery, and we should be gentle in all our manipulations. The most important two principles of assisted breech delivery are: number one, do not pull. Number two, you should always make sure that the back is facing the obstetrician. Before we go to the actual steps, the preliminary steps are: first, bring the patient to the edge of the table. This is because at the time of delivery of the head of the breech, the baby should be hanging below, somewhat like this. So if the patient is at the edge, this is possible. If the patient is on the table, this is not possible. You may put the patient on lithotomy position so that the legs won't come in the way. The third step is to catheterize the patient. This has to be done before every delivery, more so before the breech delivery. The posterior buttock climbing the perineum, you have to give a liberal episiotomy. In the vertex delivery, we wait for the crowning, but here we wait for the climbing of the breech. As I said, the most important thing in an assisted breech delivery is not to pull. You allow the baby to deliver on its own most of the time. I'm going to use this word, allow the baby to deliver on its own, at least 3 times. Everything is 3 in case of breech delivery. In a breech mechanism of labor, in a spontaneous breech, in fact, we don't allow spontaneous
breech delivery, there is delivery at 3 levels. Number 1, delivery of the buttocks. Number 2, delivery of the shoulders. And number 3, delivery of the aftercoming head. Now, in assisted breech delivery, we will have all these 3 levels, but we will allow the baby to deliver on its own most of the time. The first thing is, allow the baby to deliver on its own till the umbilicus. So, from this point onwards, the assistance starts. The cue is umbilicus. When we said allow the baby to deliver till umbilicus, the next step is pull a loop of cord so that the cord won't be snapped at the time of breech delivery. Pull a loop of cord and keep it to the side. After pulling out a loop of umbilical cord, before we go for any assistance, we will be touching the baby. So before we touch the baby's warmth has to be kept intact. Baby has a warm environment inside the uterus, so we have to cover the baby with a breech towel. And then only we must touch the baby. The breech towel should be there all the time, but now, just to demonstrate the further steps, I am going to remove the towel. The next step is the most important and crucial step, which is also a part of the principles of assisted vaginal breech delivery, and that is the back should be facing the obstetrician. Right now, the back is facing the left of the mother. So, in order to rotate this, we should not hold the abdomen of the baby because it is soft and you may injure the viscera inadvertently. For this, there is a special grip called femoro-pelvic grip. You hold both the femurs and you hold the pelvis. This is called femoro-pelvic grip. Using this grip, gently rotate the baby in such a way that the baby's back is now facing the obstetrician. It was on that side, now it is facing me. This is the most important crucial step, whether it is vaginal delivery or whether it is abdominal or cesarean delivery of the baby. The next step is to allow the baby to deliver on its own till you see the axilla. This is the second time I am using the word allow the baby to deliver on its own. First time we allowed the baby to deliver on its own till the umbilicus. Second time I am saying allow the baby to deliver on its own till you see the axilla. At this point, it is important to look at the scapulae. If the scapulae are parallel to each other like this, that means the hands are actually flexed. If the scapulae is winging like this, if the scapulae are winging like this, that means the hands are in the neutral position. So once the scapulae are parallel to each other, the next assistance is gently pull out one by one arms in the ventral surface of the body. I have delivered one arm and gently deliver the other arm also. We have to now allow the baby to deliver on its own till you see the nape of the neck. This is the third time I am using the sentence allow the baby to deliver on its own. First time I said allow the baby to deliver on its own till the umbilicus. Allow the baby to deliver on its own till the axilla. Now the third time, allow the baby to deliver on its own till you see the nape of the neck. Once you see the nape of the neck, there are 3 methods of delivering the aftercoming head of the baby. The commonest and the simplest method is Burn-Marshall technique. In this method, the obstetrician will hold the feet of the baby and will ask the assistant to give suprapubic pressure. This suprapubic pressure will keep the head of the baby flexed. That's very important. And once the baby's head is flexed, and obstetrician will just take arc of a circle in such a way that the baby's head will be emerged outside. The other method is called Mauritius-Mealy-Beard technique, wherein the obstetrician will put the baby on its left hand, the legs will go on either side, and can you come closer? And the obstetrician will put his forefinger and the middle finger on the malar eminence in order to flex the baby's head. On the right hand, he will use two fingers on the shoulder of the baby and he will deliver the baby in such a way that it comes off, the head will come off. This is Mauritius-Mealy-Beard technique. The third method of delivering the aftercoming head, if the simple technique of Bern-Marshall fails or slightly aggressive technique of Mauritius-Mealy-Beard technique also fails, then we have to go for the Piper's forceps delivery of the head. Ideal is Piper's forceps, which has got long shaft and minimal pelvic curvature. If you don't have a Piper's forceps, you can go for a long, low cavity forceps. I am using here, for demonstration purposes, a long, low cavity forceps. Now, before we use the forceps, the principles of forceps application are same, that you do a phantom application, then you choose your left blade and then you choose your right blade. But before that, we have to use the same breech towel back, but this time we will use this towel in order to wrap the baby and hold the baby up so that we won't get the limbs of the baby while I use the forceps. The assistant will wrap the baby and hold the baby in a towel. The only difference of applying forceps in a vertex delivery and aftercoming delivery of the head is that you will use the left blade like a spoon holding fashion and it will be guided with the right hand. Instead of putting posteriorly, because if you put posteriorly, you will be harming the face of the baby. So, we will directly go to the left side of the baby. So, and we will insert the blade to the left side of the baby. And ask the assistant to hold the left blade below. You hold the right blade in the right hand and guiding with the left hand, you directly go on to the right side of the baby's head. And once you have a proper grip of the baby's head, then you try to deliver the baby in the same arc of a circle so that the baby's head is delivered. Once the baby is delivered, you hold the baby slightly lower and allow at least 1 minute so that the blood will go into the baby. And after that, clamp the umbilical cord at two places, cut it and hand it over to the neonatologist. The delivery of the placenta. You wait for the signs of separation of placenta, that is fresh gush of bleeding, apparent lengthening of the cord and a suprapubic bulge, and you can actually see that the placenta is almost there at the external os. So the most important thing at this juncture is to follow the principles of active management of third stage of labor. Within 1 minute of delivery of the baby, you have to give 10 units of oxytocin intramuscularly to the mother. That will hasten the process of separation of placenta, and once the placental separation is confirmed, you perform controlled cord traction. What are you controlling? You are pushing the fundus up. Can you see this hand? I am trying to push the fundus up. This is the control, and I am slowly trying to pull the placenta. So controlled cord traction. Once you deliver the placenta, the third part of the active management of third stage of labor is actually a part of prevention of postpartum hemorrhage. That is, if there is excess bleeding, you can massage the uterus. I am going to now demonstrate one of the three difficulties that one may face at the time of assisted breech delivery. The first is an impacted breech. Now, if this is the case, then we have to use what is called gentle breech traction. You can put two fingers at the hip joint where there is flexion at the hip joint and extension at the knee joint and try to gently bring out the baby. This is called breech traction. The next maneuver I am going to demonstrate is what is called Pinard's maneuver. This can happen in an extended breech where the legs are extended. There is a flexion at the hip joint, but there is extension at the knee joint. So it's difficult to deliver the legs. So what we have to follow here is the Pinard's maneuver. You go along the ventral surface of the leg and press gently on the popliteal fossa. When you press on the gently popliteal fossa, this leg gets flexed. Once the leg gets flexed, you can catch hold of the ankles of the fetus and gently deliver this leg. Repeat the same procedure. Go along the ventral surface, press at the popliteal fossa. Once you press the popliteal fossa, this leg also will flex, catch hold of the ankle and gently remove this leg. This is called Pinard's maneuver. The third difficulty one may face in delivering the arms which are in nuchal position. So for this, the easiest method is called Lausset's maneuver. The principle here is you rotate the arms in such a way that the anterior arm becomes posterior and posterior arm becomes anterior, and in the bargain it gets delivered. So when you gently rotate, as you can see here, I am just rotating the baby and this arm gets delivered. And then the reverse rotation, this arm gets delivered.
It's time for self-test. Fill in the blanks. The incidence of breech at term is dash. Most suitable type of breech for vaginal delivery is dash. Commonly performed vaginal breech delivery is breech extraction is performed in two important principles of assisted breech delivery are three methods of delivering after coming head are extended legs are delivered by dash maneuver. Nuchal arms are delivered by dash maneuver. Now the answers. Incidence of breech at term is 3%. It is 30% at 30 weeks. Most suitable type of breech for vaginal delivery is an uncomplicated frank breech. Sometimes we may allow a fully flexed breech also. Commonly performed vaginal breech delivery is assisted breech delivery. Breech extraction is performed in emergencies only, for example, second of the twin with cord prolapse. Two important principles of assisted breech delivery are never pull and keep the back anterior always. Three methods of delivering after coming head are Burns-Marshall technique, Mauricio Smellie-Viet technique, and Piper's forceps delivery. Extended legs are delivered by Pinard's maneuver. Nuchal arms are delivered by Lausset's maneuver. Thank you for watching this presentation.